Well, hello and welcome to our seventh component on our Implants A to Z series, looking at implants from a restorative perspective. This, for me, is one of the most exciting parts of our whole system because it really brings together all of the techniques that we've worked so hard to develop, from treatment planning to patient management, provisionalization, final restoration, technical issues with all those components that allow us to get the best possible results. What's difficult in this presentation is to understand that the maxilla and the mandible are very different. We're going to talk about them together, but I want you to listen to the subtle differences between the two arches. We have aesthetic issues, we have phonetic issues. We must look at those arches very differently if we're going to be successful in our treatment. We also have to understand the individual patient. What makes these cases so challenging sometimes is just the patient we're dealing with. It's often an older patient. They may have medical issues that we have to overcome, but often almost every one of these patients have some sort of psychological challenge. They're afraid, they're concerned, the costs. There's so many issues in trying to understand how to manage the patient. So for me, this is a challenge that really can be overcome, and it's very exciting. So how we look at the individual patient, how we understand that individual, I think is paramount to getting a good result. This is one way we like to look at all of our patients, is that we try to find out why they're there in our office. What is the most important thing to you? For this patient, it's skydiving. What's important to her? That her dentures stay in her mouth. Do we think of that when we think of grandma? No, we don't. But this is maybe what we see more today. We see very active people, regardless of their age. They want to be able to do things. They want to have a normal life. They want to be able to talk. Most of them don't want to skydive, but grandma certainly did. So we need to understand right from the beginning why that patient's in our chair. So why do we want to do implants in the edentulous maxilla? What are some of the things we're thinking about? Improve retention? Well, of course, implants have that potential to keep a removable device in place. But I'd like to point out that just putting 2 implants in the second premolar area, one on each side, is not going to help that patient. Almost to every one of them will not be helped by that. So we need to understand the restorative limitations and advantages of placing implants and realize if really placing implants in a very limited way is going to have any value to the patient. Can we open the palate? This is a tremendous advantage to the patient. If we think in terms of giving the patient back what they've lost, an overdenture that replaces the missing bone and soft tissue, puts teeth in the right place, has interdental papilla, but doesn't cover the palate, might be a tremendous advantage to the patient. It doesn't alter speech or taste sensation. It really does everything the patient wants without any of the negatives. Do we want to do fixed? Of course, I think most patients think of implants as giving them a fixed final result. They're excited about that. That's what they're looking for. Is it the best treatment for the patient? Well, that depends on the magnitude of the bone and the soft tissue that's been lost, the cost that the patient can manage, and all those factors together to give us the best possible result. Part of that comes from communication, and that is, again, a theme to what we try to do. Implants, I believe, will help preserve the bone. Is that the reason to place implants? Perhaps. Is it the only reason to place implants? Well, maybe, but we have to look at those cases carefully. It's not a primary issue for why we're going to place implants. But I want to point out, placing implants has nothing to do with the restorative issues. Placing implants don't provide lip support. Placing implants don't really give us aesthetics. The most aesthetic restoration might be a full denture. That has nothing to do with the implants underneath. The implants might improve the functionality of that denture, doesn't necessarily improve aesthetics. In fact, sometimes aesthetics are much more challenging once we have implants placed. But let's compare that to the mandible. The moderately to severely resorbed mandible, why should we use implants? Well, let's have to look at really conventional treatment. Do we ever get a satisfactory result with a conventional denture? We get patients that accept them, but they're never a great result. In fact, over the last 100 years, the biggest improvements on conventional dentures has been the use of super Wernicke's powder in relationship to regular Wernicke's powder. I mean, it's just absolutely worthless. When you combine that with the reality that wearing a denture leads to progressive bone loss and a worsening of the situation, there might be a reason alone to place implants in the mandible. So we do think about this a lot. You remember my favorite slide. We sit there and we think about these things. And so let's talk about the treatments that are available to us, the advantages and limitations, and most surprisingly, the need for interocclusal space, for restorative space. A lot of times, one of the biggest mistakes I see with the edentulous patient is the assumption that if we lose teeth, we have room for restoration. So even for an edentulous patient, should implants be placed with a restorative goal in mind? Here's an example of a case where a patient had a horrible car accident, of occlusal trauma, facial trauma, teeth were fractured and broken. The teeth were removed the same day implants were placed. So there's been no bone loss. The patient was told they just needed overdentures. When the patient was talking to me, the abutments on one side were actually contacting the remaining natural teeth. So if we're having phonetic clearance problems already, how can we restore this case? The patient was upset, they didn't realize the cost, there are not enough implants. When you look at the red swollen tissue around the natural teeth, these are fractured also, they need to be removed. The patient's upset because implants were placed before there was an understanding of the restorative needs of the patient. So just removing teeth doesn't necessarily give restorative space. These are the sorts of cases we need to do a porcelain fused to metal restoration, which has the least amount in terms of a requirement of restorative space. That's an enormous difference in cost compared to an overdenture. So we need to describe and talk about the minimum dimensions for restorative space. When I'm doing these cases, there's never enough space unless I'm doing porcelain fused to metal. How much implant support do we need? We've heard over the years, all on four, two implants will support one whole side. These sorts of things, what's real and what really can we depend on? So we need to think a little bit stronger. It's not just placing implants. And then the other extreme is we're going to ignore completely that we've lost bone, soft tissue, and teeth. And we're going to try to turn our implants into natural teeth. We're going to put prepped abutments on top of them and just cement crowns. And when we look at the outcome, when we look at the fit and the retained cement and the attempt to obturate phonetic issues by leaving cement between crowns, by totally ignoring the fact that the patient has lost bone and soft tissue, we have to expect that we're going to have a minimal quality outcome. We're not just replacing teeth, we're replacing bone and soft tissue. And that's the challenge. When we try to turn implants into prep teeth without also understanding we got to replace the soft tissue, we'll have big issues. Another thing that I look at a lot is overdentures and how we manage the forces being applied. So many times it is completely ignored. We're just going to put in retentive points without an understanding of how the overlay actually works on top of them. There is always some sort of desire of the restoration to have an axis of rotation. It wants to rotate and move, relieving stress. So if we don't build that in, it becomes an implant-supported restoration that may put undue stress on the implants, on the implant abutment interface, or the restoration itself. We've seen bars break, we've seen restorations break, we've seen everything possible that can happen when we ignore the force being applied. So individual attachments, we need to talk a lot about because they don't necessarily cure all our problems. And too often I hear people only want to think of overdentures in terms of individual attachments. And then they go off and do them and have all sorts of problems because they don't understand the limitations or what we need to have a good outcome. So we will talk about that today. So how do we place the implants to get a good result with individual attachments? Do we have to worry about the soft tissue? We seem to ignore that. Oh, it's an overdenture. We don't need to worry about it. We feel that you do. What effective attachments are available and how should we use them? For me, it's what's the lowest maintenance. If I have to change an attachment every few months, something is wrong. Most of our cases go literally for years, if not a whole year, much longer than that, before we have to change any kind of an attachment. and then changing the attachment. I don't want it to be something that I have to regularly cold cure intraorally. That is a challenge and it's difficult, so I'd rather have attachments that are easy to change, but I don't want to do it very often. So I guess I could make some other questions. What's the more difficult and expensive restoration, a fixed hybrid or removable overlay? And many of our removable overlays are much more challenging than the hybrid fixed. It may have advantages, but it's not easier. It's not less expensive. In fact, the lab bills might be more for the overlay than for the fixed hybrid. What is easier, more predictable, screw retained or cemented? You know, for us, full arches, we like screw retained. It's easier, more predictable. I can do more things with it. Rarely do I have enough bone and soft tissue to cement a case. I mean, that is just not going to happen. I've lost a lot of everything. The easiest way for me to restore that is with a screw retained restoration. We need to accept the fact that it is more of a challenge in implant dentistry to take an accurate final impression than it is with conventional teeth. We need to make an extra effort, like we learned in the second lecture, to make a impression coping, splinted impression so that we get an accurate impression. We have to make an effort at this point. So as we think about the edentulous patient, really, you know, what are the keys? What are we looking for? I love to say patient selection. What does this mean? It means someone we can work with, someone we can communicate with, someone that has a reasonable expectation for what we can do for them, that we can expect to come to their visits and be involved in treatment. If they can't do those things, we really need to ask ourselves, and certainly the patient, if we can work together, because they have to be part of the team. If everything you do, they fight, you're not going to get the result that you want to have. During case workup and treatment planning, we really determine this. Can we work with the patient? Are they reasonable? Do they accept the treatment? Do they realize the costs involved? Do they accept the costs? If they're trying to cut corners at every level, can you get the result that they want to have? Because they're dictating treatment and they're cutting corners. So you have to do the case correctly and they have to be part of that treatment. Selection of an implant system. Every case has slightly different needs. You know, people say, hey, we've evolved from a hex-headed implant, yet I do full arch cases with hex-headed implants because they work quite well in bridge situations where we're linking them together. They may not be great for a single restoration or where I have to keep every bit of bone surrounding them, but that might be the best way. So we keep an open mind and we choose whatever implant works best for that individual patient. I'm so fortunate to work with great surgeons who understand technique, who can talk to the patient, explain the challenges, and then maintain them to the highest level. During our treatment planning, we're talking to the surgeon about the abutment or the method we're going to use to connect our restoration to the implant. It may be a direct connection, like in this case, with a UCLA abutment that's part of the final restoration. So there's different ways that we can manage these cases. For me, impression technique is critical. If I have an accurate model that I can be incredibly confident will be exactly the same as we have intraorally, I can do about anything I want and know that I go to the patient, it will go to place. And that gives me the comfort zone I need to have really to manage these big cases. We use provisionals to take care of the patient during the course of treatment. It might be multiple provisionals. It might be an initial removable provisional, and then a implant-supported provisional, and then alteration of that provisional until we get the result we want. And then what we like to think is that the final restoration almost happens immediately. So for a general review of options, we can do removable edentulous treatment where we might do a conventional denture. We can also do an overdenture. And we're going to try to point out that there's two different kinds of overdentures. Implant assisted, where we build in an axis of rotation, and implant supported, where all the load is taken up by the implants. Two very different overdentures. We can also do a fixed treatment, and that might be a porcelain fused to metal restoration. It also might be a hybrid restoration, or the fixed bone anchored bridge, which is a hybrid between a titanium framework or a gold framework, acrylic resin, and denture teeth. So again, just to define a little clearer the difference between implant-assisted prosthesis, the forces of occlusion are shared between the implant and the mucoperiosteum. The implant-assisted restoration will always be removable. There's no way to make that fixed. However, the implant-supported restoration can be fixed or removable. All the forces are borne by the implants. Whenever we make a bar and it's removable, the restoration, it's still a bar that all the load is being taken by the implants. Sometimes the way we place individual attachments also leads to an implant-supported prosthesis because we've eliminated an axis of rotation. And that's when we start to have problems with individual attachments. So all fixed restorations are implant-supported, some removable restorations. So how about a full denture? I think sometimes it surprises people when I say that the most aesthetic result for the moderately to severely resorbed patient is a full denture. Is it the best result for the patient? Probably no, especially in the mandible. But in the maxilla, if we have extremely atrophic maxilla, we have no place to put implants, we have a patient that from a health point of view really can't manage a big bone graft, the full denture in the maxilla might be very reasonable. We would hope in the mandible we could at least put a couple implants to help stabilize it, but we'll look at that a little bit more. Can we do an overdenture? In the maxilla, we like at least 4 implants. If we have that, we can open the palate. We can build in an axis of rotation like with this bar design. So that can work very well. We can do an overdenture. We can also use individual attachments. But I think that there's more prosthetic concerns with using individual attachments, with the placement of the implants. The long axis of the seat of these attachments is based on all the implants. If they're spread out at varying angles, it can make it extremely difficult to make an overdenture that works effectively on top of them. The hybrid restoration, or the use of a rigid metal framework with acrylic resin and denture teeth, is kind of the classic restoration that Dr. Bronnemark showed us 30, 40 years ago. Those restorations work well when we respect the amount of bone and soft tissue the patient's lost, the lip position, their need for phonetics. So there's a lot of issues we have to look at, and really we need enough space. Where we run into issues is when we have a limited space, we need to do a porcelain fused to metal restoration, and we've quoted a fee for a hybrid restoration. We can get into big trouble here. These are not easy restorations, though, the porcelain fused to metal. They're the most expensive, they're the most demanding from a technical point of view, and it's something that we need to do to really educate the patient that a fixed restoration has an enormous variability. And sometimes I tell the patient, especially in the mandible, the porcelain fused to metal is not the best way to go, the hybrid is. But they might have in their mind that I want a porcelain restoration, I want it perfect. But we respect the fact that we have a much higher incidence of porcelain fracture when we use that sort of restoration. We do need to think a little bit about how we're going to manage the occlusal forces. With the edentulous patient, let's say it's somewhat more predictable than with a partially edentulous patient, where we don't really understand sometimes completely how that individual patient might be loading that area or doing different things. But when we can look at the full arch and we get an idea how we can place implants, we can start to extrapolate out the load-bearing capacity of the case, the quality of the implant anchorage, the distribution of forces. We can limit maybe distal extensions so that we don't have maybe even more than first molar occlusion, maybe even just barely more than a second premolar occlusion. That may be a way to manage force. So we'll limit cantilevers based on the reality that we have for that individual patient. We like to look at an anterior-posterior spread, and during our treatment planning, we're trying to plan a case that will maximize this anterior-posterior spread. And probably the simplest way that I can explain this is that if you looked at your dining room table and you realized that you pushed all the legs of that table right to the middle, and then you sat on an edge of the table would fall over. But the more you can spread those legs out, the more load that table can manage, and even more importantly, the more you could have a leaf extending away from the table, and that also could be supported in terms of the load. So we want the greatest possible anterior-posterior spread, and we can use that to kind of analyze how far we can cantilever from it. And I think that's something we need to identify. So if our goal is the biggest possible AP spread, we also have to consider what's the quality of the implants underneath. If we get a big AP spread, but we had to really shorten the implants or narrow the implants to do it, that doesn't have the same value. So we would like the strongest possible implants with the biggest possible AP spread. Let's look at a classic case. And we see the sinus architecture, and for whatever reason, we're not going to assume we can do a sinus lift, which has become somewhat standard today. But we're going to place 6 implants, and we're going to place them as we can according to the sinuses and the bone available. And we might end up with this rather characteristic push of the implants towards the anterior segment and a minimum of the anterior posterior spread. And we'll discuss that there is a limit to the maximum cantilever we can do off of this. Just from doing hundreds of cases and looking at the success and failure rates of those, whether it be at the implant level or at the restoration level, there is a maximum cantilever we should do. And when we realize we need occlusion back to a certain point and this AP spread won't give it to us, we have to do something different. So perhaps we need to do something removable, even with 6 implants. And today we hear a lot about something called the all-on-4. And here we're going to place our implants a little differently. We're going to place much longer implants posteriorly that follow the wall of the sinus with a posterior inclination so that we'll greatly increase our anterior posterior spread. We may not even be able to place 6 implants because of that posterior angulation of the distal implants. But in doing that, such a big AP spread with really longer, higher quality implants and implant bone interfaces, we should be able to cantilever the amount that we want and get a fixed restoration with only 4 implants. So it's not just the number of implants, it's the length of the implant, it's the angulation of the implant, it's the anterior posterior spread that gives us the ability to support the load correctly. So, looking first at the mandible, let's try to identify what our anterior posterior spread can give us in terms of a cantilever. If we have usually 5 implants or 6, depending on their placement, we can assume that we'll have a certain anterior posterior spread. From a surgical point of view, you're trying to place those distal implants as close as possible to the mental foramen, which is a challenge. I mean, we know that there's an anterior kind of a J turn to the nerve, and we can't get too close to the foramen, but we also want to try to get as close as possible. Placing the anterior ones as far anterior as reasonable for the restoration we're doing gives us the anterior posterior spread. From that, we can assume a certain cantilever. In this case, we're designated as A. And we find in the mandible, because of the quality of bone that we normally have, because of the type of implant placement that we get, we can cantilever about 1.5 times the anterior posterior spread. So if we have a 10 millimeter spread, we can cantilever 15 millimeters very predictably. Can we go to 20? That's the maximum I would even consider, and the original Brandemark data was that. But I like to minimize it. If I don't need to go anywhere near that, I'm not going to do it. So usually for us, 15 millimeters is more than enough. We do think differently in the maxilla. But let's look at just kind of an example of a mandibular anterior posterior spread here with 5 implants, and the fact that we can consider really this 1.5 times the AP spread. We might go to something in that range, and that allows us to create a distal cantilever. This allows us, and a lot of people forget about this, but we can keep our implants anterior to the mental foramen. If we keep the implants anterior to the mental foramen, the surgery is much easier. I see more problems with implants placed posterior to the foramen when the bone is narrow, the tissue is not good quality. We tend to have issues. So I don't have a problem with 5 good implants anterior to the foramen with a good anterior posterior spread, and then a cantilever of about 1.5 times the anterior posterior spread. The maxilla, though, has the same theory, but due to the quality of bone, we tend to limit the cantilevers that we'll get from that. We often, usually, in a conventional situation, have more implants. Both the mandible and the maxilla, in regards to the all-on-4 technique, could be done with 4, but realize those implants are placed at an angle and much longer than normal. If we're using conventional length implants, 6 implants in the maxilla may be the standard number. So again, we're going to look at the anterior posterior spread. Often we're able to achieve more AP spread in the maxilla because of the position of the sinuses, and we're able to get the implants a little bit more posterior. We might get as much as 20 millimeters on an anterior posterior spread. And then that allows us to generate a cantilever. And that cantilever is reduced, though. Really, and I'm more on half that spread and never more than 10 millimeters. I might go up a little bit more than 1/2 times the AP spread, depending on the length of implants, the quality of the bone in terms of the report from the surgeon, and what I can do. So smaller cantilevers in the maxilla, bigger AP spreads because of the quality of bone. So what we'll do in the mandible, it's quite common to create a hybrid restoration, 5 implants, a significant cantilever, usually 15 millimeters or less, achieve a first molar occlusion. We can get a very good result, very predictable. Why wouldn't we get a good result? And when we look back at one of the first cases we did 30 years ago, look at the AP spread on this case. These are also gold cylinders with very small gold screws. Huge cantilevers because they just said, well, you can cantilever 20 millimeters, but no consideration of the AP spread was made. So we ended up with lots of problems. And I think this colored our image of dental implants at that time. We didn't want to do bridges. We didn't want to do cantilevers. But it was because we really didn't understand the forces being applied. The worst scenario is something like this, with excessive cantilevers, probably bone implant interfaces that weren't very strong, overloading, and the loss of bone, are really a terrible loss. I would expect with this sort of destruction in this posterior situation that there probably was an implant fracture. And when this restoration came off, I almost guarantee that the head of the implant's fractured. This is the sort of thing we just don't see anymore because we plan the cases more correctly. If we can't cantilever to the degree we need to, we're going to do a implant-assisted restoration that is an overdenture. We can't do fixed. So what are the issues that we find with the edentulous mandible? Just a quick kind of summary, then we'll move on from there. Implant anchorage. We tend to have more dense bone as long as we have enough of it. The anterior segment is the issue. So we usually have good quality bone, although not that biologically active, but sometimes we're limited in quantity. As we move posteriorly, we have the mandibular nerve, the mental foramen to be concerned about, and that might limit our ability to place implants in the posterior mandible. That leads us to this issue of cantilevers and biomechanics, and I really believe strongly we have to respect the anterior-posterior spread. I see more problems with posterior implants in the mandible where we've ignored the quality of the soft tissue. If we allow unattached tissue to remain around an implant that had a very narrow bone structure to begin with, we tend to see more bone loss in those areas, and I'm very concerned about that. We're aware of the maxillomandibular relationships and the fact that the implants have to be placed in the right position to give us the result we want to have. And what is the nature of the opposing occlusion? If I'm working in the mandible, I have a full complement of maxillary teeth, even to the second molar. Is that reasonable to expect that a fixed restoration in the mandible with a significant cantilever can really support that? So we have to look at how the patient is using their individual mouth. What's the interocclusal space? Is there room to restore if we place the implants right at the level of bone? What's the aesthetic needs? What's the smile line? The mandible tends to be a little bit easier. We don't tend to have the same aesthetic demands that we do in the maxilla. Always, especially for this population group, we tend to be concerned about hygiene. They may have lost their teeth because of poor hygiene. We need to understand that they need a way to clean their mouth in a reasonable way. I've had patients come in, and in the past they've been restored, and they're used to whole restorations being removed from their mouth to be cleaned and put back. Something is wrong if you have to take the restoration out of their mouth just to clean it. We need to design these cases in a way that they're hygienic. So we have to plan for restorative space in order to do that. What are the functional needs of the patient? Are they skydivers? Or do they talk in front of people? Are we concerned about airflow? Lots of issues come into play that we need to understand. And always there's cost issues. You know, I don't care what the cost is you ultimately charge the patient, it can be too much. It's sometimes never an appreciation unless they really value what you're doing. So your job is to educate them the reasons it costs a certain way. For me, you know what I'm thinking about in the mandible, again, quantity and quality, or the density of bone. Usually we have good density, good quality, but sometimes reduced quantity. The ridge is extremely resorbed, but more important than vertical resorption is buccolingual dimension. If the ridge gets narrower beyond a certain point, we may not be able to place implants. The shape of the mandible, aesthetic potential, clearance over the mandibular nerve. So for these edentulous cases, we need to get out of the thought that, well, I need an implant in the first molar area. We might not. We may have the ability to cantilever into those areas or use an overlay prosthesis that's removable to manage the distal areas where we can't place implants without a very traumatic surgery for the patient. We understand the mandibular canal anterior extension for the metal foramen may limit how far posteriorly we can place our implants, which affects our anterior posterior spread and how far we can ultimately cantilever teeth. A big issue that comes up, I shouldn't say a big issue, but something I hear regularly is the mandibular flexure issue. Well, if we keep our implants in the anterior mandible, that part really doesn't flex that much. It's more in the angles of the mandible posteriorly. And I have never seen a case where we've lost bone or had issues because of that flexure, but something I think that's reasonable to understand. Is it important to keep the implants anterior to the metal foramen because of flexure? I really can't say. And again, I haven't had any issues that really were brought to the fore because we placed implants all the way around the arch and splinted them together. What are some of the other issues that we might have? You know, it's surprising because, you know, on an x-ray it might look like there's plenty of vertical height, but we may have buccolingual dimension problems with bone in the mandible. Less than 7 millimeters. We place an implant into that site, the chance of causing iatrogenically fracture of the mandible is enormous. I mean, just having 1 or 2 millimeters of bone remaining in a very small mandible may lead to fracture. Lack of attached keratinized tissue. You know, for years I think people have ignored that. It's not an issue. It's an edentulous case. It's going to be an overdenture. I think the skills of our surgeon have increased to the point that we should expect to have some attachment around our implants. They really shouldn't be coming out through unattached tissue. It facilitates hygiene. It facilitates the patient's ability to manage the case, less irritation, less soreness, and we get a better outcome. For me, the biggest challenge that I have is managing the lack of interocclusal space. This starts with the overdenture. The assumption that, well, we've lost the teeth, we're going to place implants. When I don't have enough room to fit in individual attachments or a bar and the superstructure and the denture itself, it's incredibly difficult and becoming increasingly expensive as I have to do more and more things to manage it. We need to plan these cases so that we have enough space. If the implants are placed and we have no room, we may have to do a porcelain fused to metal restoration, which is extremely expensive compared to a hybrid or an overdenture. So we need to plan for the amount of interocclusal space, especially when teeth are being extracted just because they're fractured or decayed, not because of bone loss. We have big issues. The severely resorbed mandible, where we're down to implants being placed in these very narrow amount of bone, takes great surgical skill, for one thing, but it takes a great deal of care. Are we going to cause a fracture in that mandible because of the way we place it? On the other side, if we place 5 implants in this anterior mandible, which looks pretty good, there is the potential by unloading the posterior mandible, so we're not putting a denture pressing onto that soft tissue and bone, that we actually see reossification and strengthening of the mandible with time. So there is value to the patient, but we can't just assume that it's just some simple thing, and certainly it's possible that the mandible itself could fracture from placing the implants. Here we see an example of 3 implants being placed, which is not my preference in an anterior mandible, and we see a fractured mandible. And it didn't happen right where the implants were, but certainly something led to it. And this is the sort of situation we really don't want to have to deal with. I believe there was a 4th implant that was fractured in that area and then was removed. One of the biggest issues that I see is, retained natural dentition that tends to extrude, or perhaps it was that way from the beginning. So we have an extruded segment, maybe the anterior mandible. It's pulled the bone with it. For whatever reason, we decide to extract those teeth. We place the implants at that level. That will lead us to a situation where we don't have room. We don't have restorative space. So we need to plan for it, and sometimes a significant alveolectomy. Sometimes right down to the apex of the extracted tooth. So the osteotomy from the extraction, we go right to that point to place our implants. We need enough restorative space. When we're doing a case like this, and especially if we're considering an overdenture, the last thing I want to hear from the surgeon is that they grafted laterally and they placed the implant 3 millimeters to the emergence profile. I can't restore that case with an overdenture. So what are the options? Again, just for the mandible, we might do an implant-supported overlay. Here we see bars that will not allow an axis of rotation. So when the denture snaps to place with hater clips over these areas, and this could be done as a milled titanium framework today, we will get a overlay that's completely implant supported. There is no axis of rotation, so we need strength to this framework. We need enough thickness so that the framework itself won't break. But if we have a reasonable anterior-posterior spread and we don't overdo the cantilever of the restoration above it, it should work well. And that's kind of the basic design that will not have an axis of rotation built in. You can put in 5 hater clips. This could be so retentive that some of your elderly patients actually can't remove it. So that's an issue that you have to plan for. We can also do implant assisted, and this could be in the mandible as simple as 2 implants and a little bar. An interesting number, at UCLA we've been doing this for over 30 years with residents with no experience, with a lot of experience, and you wonder what our success rates. And we have had a 100% successful situation. We have never lost an implant on a 2-implant overlay. It's a good number. I like that number. But do we consider other things? Of course, with 2 implants and a bar, we have to consider axis of rotation. How will the denture move? So if we use hater clips, they can rotate around the bar, relieving stress. That's the purpose of an implant-assisted restoration. This is a very successful outcome. In the mandible, 2 implants can be placed in the right position. They can work quite well. We can use more implants and still do implant-assisted. On the extreme bruxing patient that tended to break everything in their mouth, I really would like to build in stress relief. So even with 5 implants, there's 2 hater clips, 2 ERA attachments, but when the patient bites down, the denture actually rotates around the hater clips in front and drops vertically on the ERAs, reducing stress. So we'll have less problems. We can use individual retention in the mandible, and for me, as long as I have some attached tissue and the implants are placed somewhat parallel to each other, we can get a great outcome. So the fixed bone anchored bridge in the mandible, for a fixed restoration, just a beautiful outcome. We don't worry as much about hygiene access. We tend to close it down a little bit more than this early type bridge we did, but look at every patient. If it's not an aesthetic issue, you want to make it hygienic, don't make these spaces overclosed. There's no reason. We use these for the moderately to severely resorbed mandible with outstanding outcome. We don't have issues with phonetics, with airflow control, with food bolus control in the mandible like we do in the maxilla. We can also do porcelain fused to metal. These are much more challenging. They depend on a good implant support. What are your comfort zone for cantilevers are not the same as for a hybrid restoration. I'm going to restrict them much more because of failure of flexure of the framework, breakage of porcelain because of that. So even though we can cantilever at an implant point of view, maybe like we've discussed 15 millimeters, because we have limited space, we have smaller metal frameworks, we're baking porcelain on top of them where the porcelain will fracture if we flex that framework. I'm not going to have some big cantilever, so we're going to limit it. Why would we do this case? Because we have limited interocclusal space. This is a very challenging case. There's very limited interocclusal space. In the mandible, for an implant-supported prosthesis, I'd like implants in that 8 to 10 millimeter range. I'd like 4 would be my minimum. And I'm going to have at least an AP spread of 1 centimeter. Then I could cantilever a bit from it. The one thing you have to think about is the strength of this bar. If it's going to be an implant-supported restoration, we need to have enough strength to this bar or you'll see it break. So there needs to be 3-4 millimeters of vertical height to the bar for strength if it's going to be an implant-supported restoration. If you don't think you can do implant-supported, we'll do implant-assisted. Again, 8 to 10 millimeter implants. We need at least 2 to do a 2-implant bar, but 4 gives us a very nice result. If we want to have axis of rotation, stress relief, we'll design it as an implant-assisted restoration. We don't have to worry about anterior-posterior spread because there's not an implant support, and we'll have an axis of rotation that we plan for. So basically, from a mandibular point of view, we've covered a lot of the issues that we see. And now let's look at how it's different with the maxilla, because it is a different issue. We have the same concerns about anchorage, but the bone quality is usually not as good. We have a softer bone, more cancellous type bone. We also have fairly pneumatized sinuses often to deal with. We have to question sometimes the predictability of grafts, and then certainly the resorptive patterns that we see in the maxilla. As the maxilla resorbs significantly palatally, we end up with a pseudo class 3, and it makes it much more challenging to create the correct maxillomandibular relationships that we're looking for. So even though skeletally we might be class 1, we end up in a pseudo class 3. We have to look at interocclusal and restorative space. Even though we're placing the implants in a very resorbed maxilla, we may be placing them palatally where the bone hasn't resorbed, and that may affect our restorative outcome. In the maxilla, it's really required that we're able to achieve lip support. It's much more demanding. In the mandible, we can get by with just having teeth in the right position tends to support the lip correctly. In the maxilla, we may need a flange to carry up all the way beneath the lip to truly create the correct lip support and phonetics. Do we have an aesthetic concern, a smile line? That's really the individual patient. But all of our patients have hygiene access issues, and we're going to look very strongly at those. The functional needs, and of course, as always, what is the cost and how can we control it? The maxillomandibular relationships, mainly thinking about interocclusal space, we need to look at every one of these cases, mounting them up, and really seeing what we ultimately have. Here's a great example of a case that was sent to us from the surgeon. He was excited because there was a lot of bone over the sinuses. When we have all that bone over the sinus, they can place implants directly. But then we mount up the case, and if we placed implants at that level, how do we create an occlusal plane? We end up with extruded maxillary teeth, a reverse curve, all sorts of functional restorative problems. So really, this case needed, if we're going to place implants in the posterior segment, we needed to remove bone, do a sinus lift, and place the implants correctly. You can only discover that by mounting up the case at the correct aesthetic position, vertical dimension position. So we have aesthetic space, which we might need for teeth that look right, but we also need restorative space. If we're doing an overdenture, we need room for the substructure, for the superstructure, for the denture teeth. Porcelain fused to metal, we need less room, but that may not be the right way to manage this case. Here's a great example of a couple cases that look great as the implants are placed, and the bar is done here for an overdenture, and then the patient is talking, and you kind of notice this extruded mandibular segment. Just without the denture in place, the mandibular teeth are hitting this very low-profile bar. You know, how do you manage that? It's kind of trouble now if we realize that we needed restorative space. Or if we're doing fixed and the implants are placed angled and there's no interocclusal space, and we're trying to do a hybrid restoration, it leads to prosthetic failure. So one thing we need to do as restorative dentists is to communicate to the surgeon where the heads of the implants need to be for each individual case type. So using a surgical guide, I think, is extremely valuable to communicate to the surgeon what we're trying to do. On a case like this, every alarm signal in your head should go off where we're worried because we're losing teeth from decay, not from periodontal disease. We have a full complement of bone, but let's say, for example, we want to do a hybrid restoration. When the surgeon lays the flap, removes the roots, they need to utilize the surgical guide to measure whatever number we need for our restoration and then reduce the ridge back to this. And I want to say, from a surgical point of view, this is a very traumatic thing to do mentally as well as physically on the patient. Nobody wants to take away bone, especially in the maxilla. But ultimately, we need restorative space for whatever it is. So the implants need to be placed according to that space, especially if we want to do a hybrid restoration. As in this case, we need the bone and the implants in the right position. Now, classically, as we have resorption in the maxilla, we lose bone palatally. The bone that hasn't resorbed is that palatal bone, And that will be an issue as we see, but that lack of space, if we just assume we're going to replace the teeth, will the patient accept this lack of lip support, this kind of concave look that is developed? And some patients won't. Some patients won't. How can you determine this? By planning on a good provisional that replicates what you might have to do with a final restoration as a fixed porcelain-fused to metal restoration to verify that they will accept it. And if they don't, then you have to alter your treatment and do something else. But this is a challenge. Here we just see what it looks like. You know, the patient might complain about the flange. They want to lose that flange. We put the denture in. We take the denture out. Will they manage or will they accept the lack of support? And of course, that's the extreme example with no teeth at all in there. We also will use a surgical guide. If we take the surgical guide and we make them without a flange, we put that in the mouth and we have the patient just evaluate the lip to see if they accept that. If they don't, we need to talk about a flange. We need to talk about planning this case. Maybe the surgeon can do a big bone graft. Maybe they can't. What is the patient willing to go through? Should we do an overdenture? Then implant placement is going to be different than if we're doing a porcelain fused to metal. So we have to think this case all the way through at this point, and using the surgical guide without a flange allows you to evaluate the potential lip support. If we need lip support, but we've committed to doing a fixed restoration, doing a fixed with a flange is a very poor compromise. We've had patients come to us complaining about the odor and taste. It's a denture that's been screwed to place permanently. That is not acceptable in today's world. We can't do that. Can we do porcelain fused to metal on top of implants? Perhaps. Can we make it hygienic? Perhaps. Can we do something else? We might not be able to. If indeed we need big hygiene spaces, can we achieve phonetics? Air escape, even when it's closed much more than this, can be significant to the patient with a hybrid restoration. Remember, the ridge has resorbed palatally. It's much narrower than the position of the teeth, so there tends to be a ridge in this area. Even if you close this completely, which we often do, they still complain about saliva flow over the top of the bridge and airflow issues. So you need to talk about them during treatment planning. Here's just a great case where actually my partner was kind of forced to restore this case fixed. Something I think he lost sleep over, but the surgeon had promised the patient a couple of zygomatic implants, a couple anterior implants, and we're ready to restore. But how do you restore it? So they did do a cast metal intaglio surface against the soft tissue. Did that help? Well, really no. How do you clean this thing? You thread floss in. I said put the floss in and just leave it there. It's very difficult to clean, so it's not appropriate. So if we want to do an implant supported prosthesis, we might need implants of a minimum length of about 10 millimeters. We then would need anywhere from 4 to 6, depending on the angle. As my number decreased, I would like longer implants. So we'll have better bone to implant interface. What is our anterior spread? Maybe that 15 to 20 millimeters. And then we can cantilever to some degree on a hybrid restoration, but I'm careful on porcelain fused to metal just because of the strength of the superstructure, flexure of metal, and the breakage of porcelain because of that cantilever. If we're doing an implant-assisted restoration in the maxilla, we would again like at least 10 millimeter long implants. For us, we don't really like using 2 implants in the maxilla for an overdenture. It might help, but if you think about it, on the highly resorbed cases, usually we can't place implants kind of in that 7 through 10 area. They end up being 6 and 11 or 5 and 12. Which doesn't satisfactorily manage the patient. The denture becomes a big teeter-totter that causes all kinds of prosthetic problems. So we like 4 implants for an overdenture in the maxilla. We can also do fixed on 4 if we had to, as we've talked about. When we build in an axis of rotation that comes with an assisted prosthesis, we don't have to worry about the anterior-posterior spread, but we have to think about the axis of rotation. 4 good implants allows us to open the palate, which is an advantage to the patient.
For more education programs, visit the Guide Institute at www.guide-in.org. www.guidedental.com.